metabolic syndrome. And the way I have prepared these slides, the main motive is to understand the pathogenesis behind everything, that how these things are causing all the trouble and why are they such a hot topic in today's world and the reason behind it. So main focus will be understanding the pathophysiology. And myself, Dr. Rahul Jain, and these lectures are happening under the guidance of Dr. Sharda Jain. So yes, let's move on to the topic. So coming to obesity. So the definition of obesity is a state of excess adipose tissue mass. So basically, why this definition has come, because obesity is not related to increased weight, because bodybuilders and people with heavy bones can have increased weight and they might not have excess fat. That's why obesity is state of excess adipose tissue mass, not the weight. So this should be very clear. Then the most commonly we use body mass index to measure obesity, and this is the diagram from Harrison, latest edition, and they basically, what we need to understand is that any BMI above 25 here, this point, will pose a risk in our life with weight. So with 25 it starts as low risk, then moderate, high, and very high risk. So the important thing is any BMI above 25 means equivalent to risk or the starting of risk factors related to the problems associated with obesity. Then next topic will be pathogenesis of obesity. So this we have already discussed in our diabetes topic also, that whenever there is obesity or any problem with increased adipose tissue, the adipose cells will undergo hypertrophy, not hyperplasia. So this hypertrophy will cause decreased density of insulin receptors over the surface, as you can see in this diagram, and that will cause insulin resistance. So basically, if suppose in this adipose cell the area is 20 micrometer square, so if it's 20 units, then if there are 5 receptors on it, the density will become 20 divided by 5, 4. But here, so here the density is 5, and here suppose the area is 100. So, and there are 5 receptors, so density becomes 20. So now from 5 it became 20, but the insulin doesn't rise that 4 times. So it will ultimately cause insulin resistance, and basically obesity will cause progression of insulin resistance, and we will discuss it further. What does insulin resistance exactly do? And today insulin resistance will only be our main hot topic for today. Then we'll just understand, if we need to counsel anyone about obesity, that what are the problems associated with obesity, and we should be very clear with the problems associated with obesity. So the first problem which is associated with obesity, obviously diabetes and insulin resistance. The second, infertility is also associated with reproductive disorders, and PCOS commonly associated with insulin resistance and obesity. In males, infertility to certain extent is associated with obesity. And cardiovascular disorders like coronary artery disease, stroke, heart failure, and obesity in the lungs associated with obstructive sleep apnea and obesity hypoventilation syndrome. Basically, these patients will have shallow breaths because their lungs will occupy a small space and the diaphragm moves up as they have central obesity, and they have and they will not exhale or inhale properly. So they can easily go for any kind of respiratory alkalosis and acidosis if any problem occurs. So that is obesity hypoventilation syndrome. And in liver we have non-alcoholic fatty liver disease and non-alcoholic steatohepatitis. Then bone and joint disease, we have osteoarthritis and skin disease. This is very interesting, acanthosis nigricans. So basically acanthosis nigricans is the dark pigmentation over the skin creases, and it can be seen mainly, it is a good marker of insulin resistance. So wherever you see acanthosis nigricans, we will see insulin resistance, and it makes the skin friable also. So skin will be friable, so more prone for yeast and fungal infections, and along with it insulin resistance will cause hyperglycemia. So hyperglycemia can also predispose a patient or person for infections. So any patient we see acanthosis nigricans, we should check for their sugar levels, and if they are obese, then it should give us an indication that the patient has insulin resistance. Then multiple cancers are associated with obesity, and there's one interesting entity called as corpus cancer syndrome, and it is basically obesity associated with endometrial cancer. So coming on to this much only about obesity, coming on to metabolic syndrome, which we'll be discussing in depth today. So there are 5 criteria under metabolic syndrome, and there is a reason for each and every criteria being put under this metabolic syndrome. So first of all, to understand further, we should know each name of each and every criteria. So for metabolic syndrome, we should know first of all the criteria include fasting glucose, HDL, triglycerides, blood pressure, and abdominal girth. We will understand each and every criteria, how it is part of metabolic syndrome, and why it is important to that each and every criteria plays a role in metabolic syndrome. So I repeat, there are 5 criteria: HDL levels, fasting glucose, triglyceride, BP, and abdominal. So coming on to the etiology and pathogenesis. So first of all, what is metabolic syndrome? A metabolic syndrome, or I also call it syndrome X, insulin resistance syndrome, it is a constellation of metabolic abnormalities that increases the risk of all the cardiovascular disease and diabetes mellitus. So any patient with metabolic syndrome, not yet diabetic but obese, we should counsel them that they have very high chances for going for diabetes mellitus in near future, and multiple heart conditions and heart problems. So now, why does this happen? So we need to remember this word, which is the topic for today, this insulin resistance. So there's all the factors which causes metabolic syndrome is always starts with insulin resistance. It is always the insulin resistance which starts all the pathology. So insulin resistance why insulin resistance happens? Because obese individuals have central obesity. Coming on to this photo again, that this central obesity, the adipose cells will become big and will cause insulin resistance. So the first thing which always happens in the case of metabolic syndrome is insulin resistance, and it begins when free fatty acids are more in blood. So when the patient becomes obese, the adipose cells become more in number and size, and it's the size which increases more, and they will keep releasing free fatty acids, more free fatty acids in blood. How it will cause insulin resistance, that we will discuss in mechanism, but for now, insulin resistance. Then leptin resistance. So leptin is one hormone which decreases our appetite. So even leptin resistance has a role in case of metabolic syndrome. Then we have increased waist circumference, central obesity, glucose tolerance, inflammatory cytokines, dyslipidemia. So basically, the things which are causes of metabolic syndrome are also part of etiology. So when I talk about LDL and HDL, that comes under part of dyslipidemia. Glucose tolerance will come under part of insulin resistance also, and more fasting glucose also. Then even hypertension. So hypertension is also etiology of metabolic syndrome. So BP. Then we have increased waist circumference. So that is also part of metabolic syndrome criteria, abdominal girth, and then even leptin resistance. So I hope etiological factors are clear, and we'll discuss more about hypertension. How hypertension has a role in case of or how insulin resistance causes hypertension. So basically, what we need to understand that normally insulin has vasodilator properties. So it has a vasodilator properties. Since it will cause vasodilatation, it will cause increased GFR, that is glomerular filtration rate, which will cause increased sodium reabsorption. This is normal. So basically, along with vasodilatation and sodium reabsorption, both balance each other, and it does not affect blood pressure much. But when there's insulin resistance or there's hyperinsulinemia, it is the only sodium reabsorption which is occurring and not the vasodilatory effect. So when this vasodilatory effect is not occurring, it's the only sodium reabsorption. This sodium reabsorb will cause the hypertension. I will like to revise one more point which we have discussed in our hypertension, the essential hypertension, that why does essential hypertension occurs? It is because it is to excrete higher levels of sodium, kidneys has to compensatory increase the blood pressure to excrete the extra sodium. So when this insulin resistance is causing only sodium reabsorption, it is increasing the sodium levels in the blood. So this is one important point here, that how insulin resistance will also cause hypertension and also vice versa. Then insulin also increases sympathetic discharge. So as we know that sympathetic discharge will increases blood pressure and catecholamine surge. So that is also responsible for one reason for hypertension. And hyperuricemia is marker. So any patient of hyperuricemic patient, we see that in kidney function test we see increased uric acid levels. That should also give us that should make us alert that this patient is going for metabolic syndrome associated with hypertension. Then role of pro-inflammatory cytokines is also very important. So I hope, ma'am, how hypertension and how metabolic syndrome is associated with hypertension and insulin resistance is clear here a bit.
Yes.
So the important key point is that insulin resistance causes sodium reabsorption, and this sodium reabsorption is responsible for elevated blood pressure, and insulin also increases sympathetic discharge. So why are we trying to understand this pathogenesis and pathophysiology is that even a patient of metabolic syndrome should start restricting their sodium intake. So a patient of metabolic syndrome, if does not yet have blood pressure problems, or maybe it does not increase the borderline levels, if they restrict their sodium levels, then we can reduce the progression of the disease.
Correct.
This point is very important. Then now comes to the actual pathogenesis, then how everything is working. So from these two slides of etiology, one thing must be very clear, that it is the insulin resistance which is causing most of the trouble. And one more point I will add here is pro-inflammatory cytokines, which I forgot to mention, that how it happens that macrophages, whenever there is hyperlipidemia, these macrophages in our blood will engulf the extra lipid levels. And when they engulf these extra lipid levels, they become lazy and they become hypofunctioning. They stop to function and they are called as foamy macrophages. And then they won't work and they will release all the inflammatory cytokines in the blood. So basically, hyperlipidemia will also cause cytokine levels more, and that will increase the inflammation levels in the body. So all these things, how they work together is, so again I will come to the metabolic syndrome criteria, that 5 things are important. That is girth. The criteria is triglycerides, HDL, glucose, BP and girth. So what is happening and how it is starting, it is the first girth. So first of all, abdominal obesity will occur in a patient. This abdominal obesity will cause free fatty acid release. This free fatty acid release will also trigger insulin release. Why? Because insulin's normal action is anti-lipolysis. So this anti-lipolysis action will start working. So because of this, there will be hyperinsulinemia. This hyperinsulinemia and this free fatty acids in liver will go stimulate this free fatty acid will goes into the liver and will stimulate the production of glucose. That causes hyperglycemia. This hyperglycemia will also go and again stimulate insulin release. So this becomes a vicious cycle. So first is this abdominal obesity causing hyperglycememia and decrease HDL and increase LDL. This hyperglycemia will also cause again hyperinsulinemia. That will basically makes it a vicious cycle. Then free fatty acids also decrease insulin sensitivity in muscles. So this will, because what happens in muscles, there are 2 pathways for glucose uptake. One is a insulin dependent pathway, one is insulin independent pathway. So insulin dependent pathway is a normal pathway that insulin will come, act on the muscle cell, will cause glucose uptake. The other pathway is whenever the person is exercising, the glucose will go inside the muscle cell without insulin. So that is why again we need to understand here that for these patients, doing brisk exercise every day is very important. So all the 5 criteria we have covered based on the pathogenesis. So for one criteria was abdominal girth, that is more than 80 and 94 in South Asians, and that criteria is covered here, abdominal obesity. So then second criteria was fasting glucose more than fasting glucose more than 126, that gets covered in hyperglycemia. Then HDL less than 50 for males, less than 40 for females. So that gets covered here, and LDL here we can see LDL triglycerides or LDL more than 150. So I hope everything gets cleared with all the pathogenesis, that why triglycerides more than 150 is part of the criteria, why HDL less is part of the criteria, why fasting glucose more than 100 is part of criteria, why elevated BP, and why abdominal growth. So I hope, ma'am, it is very clear from pathogenesis, everything till here,
Yes,
that everything is connected to each other. So next, coming to this diagram I've taken from Harrison. It summarizes the whole thing, whatever we have studied in last 3 slides. So basically it is saying that adipose cells will release free fatty acids. Those free fatty acids are causing insulin resistance at the level of muscle. They are also causing actions on liver. Liver is producing C-reactive protein. This is the reason we get C-reactive protein done in a regular thing, so that we know that what is a person's inflammatory state. Then liver is also producing pro-inflammatory cytokines, fibrinogen, and all that is causing pro-thrombotic state. So pro-thrombotic states will also progress the atherosclerotic formation. So all those atherosclerotic factors, like we have studied, can cause stroke, can cause heart diseases. So I think this slide becomes a summary of all the lectures and videos which we have studied in past few days. That is, what is the microvascular complication of diabetes, hypertension, hyperlipidemia, triglycerides, metabolic syndrome. Everything summarizes to this slide.
beautiful.
Then also it
also explain hypertension also.
What, ma'am? Hypertension. So then coming on to treatment. So the metabolic syndrome, as far as the treatment is concerned, the important thing is to control each and every factor individually. So for obviously, first of all, the most important thing is diet changes and dietary modifications are most important. So dietary modifications and obesity reduction, weight reduction. Then we can use drugs also, and for glucose and for diabetic people who are already diabetic, we can use anti-diabetic drugs. For elevated blood pressures, we can use antihypertensives, and again weight reduction. So treatment other than risk factor control, weight reduction, diet control, and obviously restriction of smoking and alcohol, it is control each and every risk factor. But most important thing is people who are yet not diabetic, hypertensive, but fall into the category of metabolic syndrome, they need to start doing this risk factor control and lifestyle modifications very in a very tight manner and tight controlled way, so that they prevent the progression of diseases for them in future. Then this very interesting topic is the intermittent fasting, and we'll discuss about intermittent fasting and how it works. So intermittent fasting, I've included this in mainly in metabolic syndrome, because intermittent fasting and metabolic syndrome are two opposite things. So intermittent fasting is a good reliable option for metabolic syndrome as a treatment. So how does intermittent fasting works and what is it, that we'll discuss. So yes, intermittent fasting. So basically the points which need to be understood is the five criteria for metabolic syndrome, and all five are getting improved using intermittent fasting. So obesity, that is abdominal girth, insulin resistance, which was the major pathogenetic factor in case of metabolic syndrome, is getting improved with intermittent fasting. Then high cholesterol levels, hypertension, inflammation, all those things which are caused by metabolic syndrome are getting improved with intermittent fasting. So this is very important, intermittent fasting. So first we'll understand what are the different types of intermittent fasting available for the people and how are they done. So one is 16-8 method. So 16-8 method is people fast for 16 hours and then they eat only for 8 hours in a day. So some people will start eating at morning 8 a.m. and they will go on eating till 8 hours, and after that they will fast for the rest of the time. So, but they can take water and liquids. Then 5:2 fasting is this. That this is the 2 days of the week they will fast. That is they only take 500 to 600 calories a day. Other 5 days they will continue to have their normal diet. Then their other method is 12-hour fasting. That 12-hour, they people fast in 12 hours, they'll eat, and then alternate day fasting is also a very good method. That one day they'll have a normal eating habits, and every second day they'll have alternate day fasting. Then how does anti-aging and fasting are associated? Now this is one photo I have taken from Harrison, and this is what Harrison says, if we can read. Even rats subjected to alternate day fasting live up to 83% longer than normally fed control animals, and 124 hour fasting period every 4 days is sufficient to generate lifespan extension. And another line which Harrison says is, in a spectacular experiment, mice fed a high-fat diet in a time-restricted manner, that is with regular fasting rate, showed reduced inflammation markers, no fatty liver, and were slim in comparison to mice with equivalent total calorie consumption, but ad libitum. So even Harrison says these lines in, it's very true that anti-aging is associated with intermittent fasting, and fasting is very important to cause anti-aging effects. Basically, it is the calorie restriction, and we'll understand more about it in further slides, that how calorie restriction helps us in fasting. So then we'll come to the mechanism of in calorie restriction, intermittent fasting, and how it works. So we have something called a sirtuin, SIRT, sirtuin. So this sirtuin or SIRT1, how it works is that whenever we do exercise or fasting, it makes this SIRT1 active, and this since whenever this SIRT1 is active, the oxygen consumption of the cells will fall. So basically, we are trying to decrease the oxygen consumption of the cell. We are trying to decrease the metabolism of cell, which is increasing my lifespan of the cell. So that's how it is working. So even exercise is also helping. Even fasting is also helping, and it also intermittent fasting also triggers autophagy. So it is protecting the person against malignancies, infection, and neurodegenerative diseases. So again, it is helping in increasing the lifespan, and obviously it is helping against all the metabolic syndrome conditions and risk factors associated with it. So intermittent fasting is very useful. Then what are the other ways to delay aging? It is physical activity, exercise, metformin, red wine and grapes have associated with also known to stimulate SIRT1, so helps in delay the aging. But then red wine also has some negative side effects. So calorie restriction and intermittent fasting is the best. And there is this hypothesis called as hormesis. So what is this hormesis says is that stressors in mild amount actually helps to release anti-stress proteins, and releasing those anti-stress proteins helps to delay aging. So they say whenever there is calorie restriction and intermittent fasting, it helps as mild stressors and helps to delay aging. So this is the hormesis, and that is how Harrison explained that calorie restriction, intermittent fasting delays aging, and the mechanism behind it is this. And one more evidence is this, that even rats subjected to fasting live longer and are slim, have less disease, no fatty liver, reduced inflammation. So, ma'am, this much only about intermittent fasting. I hope it was clear.
Yes, yes, yes. In fact, couple of things जो मैं practical side जानती हूँ, वो ये है कि intermittent fasting के अंदर जैसे आपने जो बताया है कि आपका बॉडी के अंदर मान लिया हम कहते हैं कि 100 मिलीग्राम पर डेसीलीटर आपका वो है, तो इसका मतलब क्या है कि आपका 5 लीटर अगर आपके बॉडी में फ्लूइड है तो आपके पास पूरे सर्कुलेशन में 5 ग्राम शुगर होगी, ठीक है। और आपका जब भी न्यू ग्लूकोजेनेसिस होगी तो लीवर के अंदर ये स्टोर होता है, तो लीवर के अंदर जो ग्लाइकोजन की तरह ये स्टोर होता है वो भी खाली 5-7 ग्राम से ज़्यादा नहीं स्टोर होगा। उसके बाद जितना भी एक्स्ट्रा होगा वो फैटी एसिड्स की तरह से आपका लिवर में फैट की तरह से अक्यूमुलेट हो जाएगा। तो क्या है, फास्टिंग से क्या करते हैं कि यू वोड योर चेंजेस फ्रॉम ग्लूकोज तो आपके पहले 2 दिन की फास्टिंग अगर आप कर लोगे तो आपका ग्लूकोज से आपकी एनर्जी नहीं मिलती, आपको फिर फ्री फैटी एसिड से आपकी एनर्जी मिलनी शुरू होती है। एंड फ्री फैटी एसिड्स का इज वन ऑफ द ग्रेट एनर्जी सोर्स, ये सबको सप्लाई करता है, भले ब्रेन को नहीं सप्लाई करता। फ्री फैटी एसिड ब्रेन को नहीं सप्लाई करता। और एक बात देखा है, जब भी फ्री फैटी एसिड आपको सप्लाई कर रहा है एनर्जी सोर्स, उस टाइम मसल के प्रोटीन्स को इफेक्ट नहीं करता। तो ये है कि कभी भी आपका, जब भी आप फास्टिंग कर रहे हो तो आपकी ये नहीं होती थी कि आपकी मसल खराब होने लगे। तो ये कपल ऑफ चीजेस है, इट्स अ लवली साइंस, एंड हर आदमी को उसके बारे में पढ़ना चाहिए। मोर एंड मोर अबाउट दिस पर्टिकुलर साइंस पीपल शुड स्टडी।
जी मैम, then coming to as ma'am beautifully said and cleared our concepts about intermittent fasting and calorie restriction, how it helps us, we'll move on to a brief introduction about nutrition and how it works. So nutrients are basically organic and inorganic complexes contained in food, and there are two types of nutrients. We have macronutrients, which form the main bulk, and we have micronutrients. So the important thing is in a diet, 50 to 60% should be carbohydrates, 15 to 30% should be proteins, and rest should be fats. So basically in a diet, carbohydrates 50 to 60% doesn't mean refined sugar. It should be complex carbohydrates, and a very small amount of carbohydrates only should be refined sugar, and that is also not necessary. Then coming to energy requirements, so 1 gram of protein will give us 4 calories, 1 gram of carbohydrates will give us 4 calories, and 1 gram of fats give us 9 calories. So imagine how fat is, how much it is a calorie dense food, that each gram of fat is giving us 9 calories. Then how to calculate energy requirements till puberty? For anyone till age of puberty, how will we calculate that how much energy they require? So suppose for first 10 kgs of body weight, demand is 100 kcal per kg. For next 10 it's 50, and more than that it's 20. So suppose a child is 20 kgs, so it becomes 100 into 10, that is 1000, plus 50 into 10 becomes 50 kcals per day. So that's how we calculate for children that how much calories we should give every day.
तो फर्स्ट 10 kg के लिए 100 कैलोरीज लगेगा, नेक्स्ट 10 kg के लिए 50 कैलोरीज लगेगा, और उसके ऊपर आपका 20 कैलोरीज लगेगा ओवर 20.
So if someone is 25 kgs, then it will become 1000 plus 500 plus 100, so 1600.
ठीक है.
So per day. Then but this body weight should be expected body weight, not the actual body weight. If a baby or a child is malnourished, then we can't start feeding him according to that weight. We have to calculate the expected weight for that child. So for those, we'll use these formulas. These are called as Veach formulas. So if child is 2 years old, then we'll use this formula, calculate the expected weight for that child, and for that expected weight, I will calculate the calories.
Correct.
So this is very important. Then coming on to energy requirements for adults. So we need to first differentiate that if an adult is a sedentary worker, moderate worker, or heavy worker. So for sedentary worker means the person does not does most of the activity the whole day, does not, he's not ambulatory much of the time, has a desk job or sitting job, then the calorie requirement is only 2320 calories per day, and for females it is only 1900 kcals per day. But people like laborers and machinery workers and all who will keep doing work the time they are doing, who keep moving here and all, running and all, for them the calorie requirement is high compared to people who are sedentary workers. So 3490 calories for heavy workers males, and for females it becomes 2800. And in pregnancy the demand increases by 350 kcals per day, and with lactation the demand increases by 600 kcals per day. So protein requirement for children is 0.9 grams per kg body weight per day, and for adults it's 0.8 gram per kg body weight per day. So suppose if there is adult is 50 kg adult, then the demand is hardly 40 grams per day for the protein. And for children, if a child is 20 kgs, then demand is 18 grams per day at least for the adequate growth. Then coming on to the balance side, and on the last topic for the day, that is balance diet. What should it consist of, and how it works. So basically, whenever we are trying to decide a balanced diet for us, first of all, we should follow the principle that the first thing is that carbohydrate should be 50 to 60% of our diet, protein should be 10 to 15%, and rest are fats. Then we should think in the mind of our daily caloric intake. So with these formulas, we can calculate the daily caloric intake. Then coming on to the third thing, we should also keep in mind that how much protein we require, and we should make sure that that protein intake is normal for us and it is meeting our needs. Then we come to this food guide pyramid that every day bread, cereal, rice or pasta, it should not exceed more than 5 to 10 servings. And then the pyramid means that the next step should be lesser than the previous step. So majority of the content of the diet will become bread, cereal, rice, pastas, maybe oats. Then next big part becomes the vegetable group and the fruits. Then even lesser is milk, yogurt, cheese and meat, dry base, and the fats, oils, sweets or artificial calories becomes the least and should not be used, or should be used the least amount. Then this one more new concept is coming nowadays, that is colorful plate concept. The concept is each time whenever we are eating, if we try to keep multiple colors in our diet, in our plate, then that will be a better diet than a less colorful meal. So our plate can consist of some colorful fruit, maybe a glass of milk, then grains, different types of vegetables and protein items. So with this, I'll conclude the today's session.
I think it was great. Very good.
And the only thing, ma'am, which is I felt is the most important is I felt was like really evidence-based was this line that
Yes, 85%.
So alternate day fasting, they live up to 83% longer than normally fed control animals. So which directly demonstrates that it is so much important for us to introduce intermittent fasting in our lifestyle nowadays. So this is it.